So this is a very different study. This is a study of metastatic castration-resistant prostate cancer. These are all patients that have already been treated with AR pathway inhibitors. What we did is a national study led by the Canadian Cancer Trials Group. And we screened patients that had had prior treatment with circulating tumor DNA or ctDNA, really looking to see if we could use that information to conduct multiple phase 2 studies where we explore whether existing treatments or novel treatments could be of benefit to patients. So I was chair of a sub-study of that larger umbrella study. So in the larger umbrella study, we've screened over 600 patients for their ctDNA, and one of the screening outcomes was what is their AR or androgen receptor phenotype. Okay, and so in my study, we had 72 patients enrolled. The patients either had one of 3 cohorts, so it was androgen receptor gain, androgen receptor mutation, or wild type, meaning no androgen receptor alteration. What our hypothesis was in this study is that in patients that had received an AR pathway inhibitor, we know that darolutamide is a different kind of AR antagonist, meaning it doesn't bind at the same site as enzalutamide or apalutamide, and certainly not compared to abiraterone. So in patients with these AR alterations, could we enrich for benefit from darolutamide? And there are some preclinical data that even say, for example, with AR mutation, darolutamide may work better, whereas it might have been a resistance mechanism to other AR antagonists. So 72 patients enrolled, 24 patients in each of the AR gain and AR mutated groups, and a few less in the wild type group. We did find that there was a modest benefit in enriching for PSA response and clinical benefit from darolutamide, that in particular some interesting findings like an SPOP alteration or certain AR mutations were more likely to respond to darolutamide. Overall though, as we know from many data, a switch from ARPI to ARPI overall has modest responses. Importantly, in this group, people did not, or patients did not have docetaxel chemotherapy, so we really tried to make it an AR switch strategy. And so, you know, I think the lessons learned from this study, we can take a large population of castration-resistant prostate cancer patients, screen them with circulating tumor DNA, identify patients that might be more likely to benefit. And I think that approach is in itself a huge effort. Can we get the right drugs for that phenotype of patient? And I think the quest continues there to have even better AR-targeted therapies.